Okay, it's just after the hour, and I think we might make a start. I know more people will join. So I'm Len Gray, for those of you who don't know me, and welcome to people that haven't been to one of these sessions before. Before we commence, I'd like to acknowledge the traditional owners of the various lands on which those in Australia live and work, and pay our respects to elders past, present and emerging. And if anybody of Indigenous background is here with us, a special welcome to you. This session with our colleagues from Alaska has in part been inspired by the fact that there's a significant Indigenous population in Alaska, and I'm sure that some of the challenges that need to be met in order to serve that community probably have learnings that we can share with similar populations here in Australia. And so, amongst other things, it's exciting to have our guests from North America joining us today. And I see, so that's Melanie, Caroline and Sherry, and I'll formally introduce them in a minute. I've learned that their boss, Tony Newman, is also on the call. So welcome, Tony, to Australia. Thanks for joining us. Good to see you. Thanks for being here, and thanks for letting your group present to us. So before we get into the presentation, I just want to say a few things about where things are at with inter-rai in Australia. George alerted me to the fact that we had a booth at the Ageing Australia conference on the Gold Coast a week or so ago. I missed it because of the COVID, but quite a number of our colleagues were there. I understand that the meeting went pretty well from inter-rai's point of view, plenty of exposure to the audience there, and it's all part of our awareness strategy in Australia, which is really critical for any opportunity we might have to see inter-rai take up in Australia. We've been prosecuting the argument for our Alaskan colleagues for about 20 years here in Australia, and the last couple of years with outworkings of a Royal Commission into Aged Care and quite significant opportunities to renovate our systems, including the data and assessment environments, has opened up the door. It's created an opportunity for inter-rai to have a place here. So that's why we're making a concerted effort at the moment. A number of us are going to a meeting with our colleagues in Vancouver the week after next, and we'll see Melanie amongst others there. This is a meeting of the integrated care and aged care groups and the hospital group, and there'll be probably 60 or 70 people there. Part of the meeting is a meeting with ChYMH, and I think representatives AIHW will be there at the meeting as well. So it's that's a special session that ChYMH is running with inter-rai to talk about matters of mutual interest, and I think that's an exciting opportunity. It'll be a great day to kind of learn. There's quite a good collaboration between Australian Institute of Health and Welfare and the Canadian Institute of Health Information, and that's a healthy relationship. We have such similar issues and similar kind of service environments that working arrangement's valuable and durable and very productive. So we'll report back on outcomes of that meeting next time we meet. The other thing I wanted to mention was that another important opportunity we have here is being sponsored and funded by the Digital Health Cooperative Research Centre. They're running a project called Kinnexus, and I'm going to share a screen for a second. Kinnexus is a production of a piece of software, and the next slide will show you what it's intended to do. It's something a little bit different. Basically, it's a smart on fire app that would be hosted by another software system. But basically what the app will do is gather inter-rai LTCF observations, calculate all of the applications, caps, scales and quality measures and so forth, generate the outputs and make them interoperable using FHIR technology. So it's basically a cut down version of what you would normally see with a piece of software for inter-rai, and its intention is to not be a standalone software solution, but to sit inside a host software solution, which could be a large EMR, for example, or it could be another aged care product that supports the aged care industry. But the value of it is that it contains all the kind of essential ingredients of an inter-rai assessment, and gets done once and it can be inserted into multiple software solutions, but it's also interoperable with the host software and with the outside world. So it makes the data interoperable with, for example, hospital software or the local primary care software or whatever. So the intent is to create that capability. It's not meant to replace traditional aged care software. It's meant to enhance it and make it, render it inter-rai capable. So basically, that's kind of a summary of what it is doing. And an important function of it will be to calculate the quality indicators that are mandated for the Alaskans. So we have a mandatory QI program. The QIs look very similar to the QIs that you would see in North America, in Canada, or in CMS QIs, and it will calculate those and make them ready for transmission to government. So this is a big renovation opportunity in Australia. This is not going to be adopted necessarily by anybody. It's a proof of concept project, but it will make available a capability that other vendors may be interested in. And there's Kinnexus the CRC is in discussions with at least 2 or 3 vendors at the moment who are interested in testing this solution. And so it will be available and operational in a research and development paradigm towards the end of the year. But I think this is a very exciting initiative for Australia. It's also very relevant to our thinking anywhere in the world about how you put an inter-rai solution inside another EMR type environment. So there is a website for Kinnexus. We'll share the link to that website, and they run a series of webinars which are demonstrating how they're developing the product, and some of you may be interested to join that webinar. So we'll make sure you hear about that through our messaging services. The final thing I'd like to say is we're very active on LinkedIn. If you're a LinkedIn kind of person, make sure you follow us and like what we send out. We're very prolific in our kind of information, and we try to keep everyone updated. We're also on X, but so both of those environments, we share our developments and interests. So, as I implied earlier, we heard about superficially about developments in Alaska and through Melanie and others, and we thought there were some interesting parallels about the challenges that Alaska might be experiencing. They're in the kind of getting it going phase at the moment, so that's always an interesting part of the evolution of an inter-rai implementation. And of course, I've referred to the nature of the population there. It's a dispersed population. Correct me if I'm wrong, Caroline and Sherry, but they've got all the challenges of distance that we have in Australia, and so telehealth and things like that are a really important part of our work here, as well as in Alaska. And of course, I've referred to Indigenous populations and the special needs that they may have, all part of the challenges I'm sure you have. Also, you're working in the younger disability populations as well as in aged care. So that's an area where there's a lot of work yet to be done with inter-rai, but it's a really important area. So we're very interested to hear what you're doing there. I know you've got your talks already. I'm not trying to change them. So I think Melanie's going to kick off the conversation, and Caroline and Sherry will contribute subsequently. I won't make the introductions because they'll do it much better themselves, and Melanie tells me they're very happy to tell us a little bit about themselves before they kick off. And I don't know if Tony's going to say anything, but you're obviously welcome to chip in, and hopefully we'll have time for some discussion at the end. So here we go. Thank you, Melanie.
Absolutely. And thank you, Lynn, and good morning, everyone. We're really excited to be here to tell you a little bit about what Alaska's been up to. So it has been a bit of a road. You'll get to hear a lot about that. We have some slides we'll be sharing. And like I think it was put into the chat, please feel free to put any questions as they occur to you in the chat. We do expect to have some time at the end for discussion. And we also want to hear your perspectives on some of our shared issues, because Alaska is very much, still in the learning phases. And while we have a whole lot of great ideas, we definitely think there are things that we can learn from your experiences as well. And so we're going to do some introductions here in just a moment. I'm going to give a brief overview of inter-rai in the United States before handing it over to Caroline and Cherry to talk about everything going on in Alaska. And then we will have time for questions and discussion at the end. And so just as a quick round of introductions, my name is Melanie Thomasson. As Lynn mentioned, I'm an inter-rai fellow. I've actually been supporting implementations in the United States for about 15 years. I'm currently a consultant giving some intense support to some states through a project called Enhancing inter-rai. And through that project, we're supporting Alaska's implementation of several inter-rai instruments, which you'll hear more about. And with that, I'll hand it over to you, Caroline.
Thank you, Melanie. So we're delighted to be here today. Thank you so much for the invitation to talk to you all about inter-rai and what we're doing in Alaska. My name is Caroline Hogan, and I am currently the Acting Division Operations Manager here at Senior and Disability Services. I have worked for the state of Alaska for almost 18 years now in a variety of positions, including as an assessor and as our Chief of Quality. Prior to working for the state, I worked in a nonprofit agency here in Alaska that provides supports to people with disabilities. And one of the positions that I held there was as a Director of Rural Support Services. And so in that position, I had the opportunity to work on the North Slope of Alaska and also in our Bristol Bay area. So I have some experience in working in the rural communities. I'm originally from Ireland, where I was a recreation therapist and a special education teacher. And I will turn it over to Cherry.
Thank you, Caroline. Good morning. Thank you for having us. It's good evening from Alaska, but good morning to you in Australia. Again, I am Cherry Herman. I've worked for the state of Alaska for 25 years in this Department of Health, in various roles supporting many assistance programs that are offered through the state of Alaska's Department of Health. I have been with this division, the Division of Senior and Disability Services, since 2014. And I'm currently the project manager for the project management unit within SDS. Our unit is responsible for planning, developing, implementing Medicaid-funded projects, which are mostly IT systems. And that's my role with inter-rai and my team's role. So again, thank you. We look forward to sharing some information with you today.
And I do appreciate that our director has joined us. And so I was going to have our director Newman introduce himself.
Thank you, Caroline. Yeah, hi, everyone. I'm Tony Newman. I'm the director of the Division of Senior Disability Services, and I'm coming to you from Juneau, Alaska, which is located in the panhandle of Southeast Alaska. And I'm here mostly because I'm just so proud of this team and the work they've done here in Alaska. And I'm also eager to learn more about what you have underway in Australia. So thank you, Caroline, and I'll turn it back over to the three of you.
Thank you all. And so I wanted to give just kind of a level setting. I know many of you probably aren't very familiar with the way that our system works here in the United States. And so we're going to be talking primarily about what we call home and community-based services here in the United States, or HCBS. HCBS services are those that are provided to people with disabilities or older people or other people with really high needs who need assistance with activities of daily living. And in the United States, the largest payer for HCBS is actually Medicaid, which you meant, Cherry, you heard Cherry mention Medicaid. It is a program that is largely federally funded, but it's administered by the states. And so there is a lot of differentiation state to state in terms of what it looks like, what it covers, eligibility, and assessment. And so it's up to each state in the US to decide how they want to assess for needs for the Medicaid waiver programs. And we call them waiver programs because it's a special kind of funding mechanism that allows states to provide services in home and community-based settings that otherwise would mean that someone needed to be in a nursing facility. So these are quite a nursing facility or another institutional setting. So these are quite, people with higher needs that we're caring for, and it's also a means-tested program, which is another thing that's important to understand. And so there is a requirement, even though the states have a lot of ability to make decisions about what their programs look like. There are some federal requirements, and one of them is that there is the use of a standardized assessment. Historically, a lot of states created their own assessment to determine eligibility and to inform care planning. But over the last couple of decades, and it's really picking up now, we have more and more states turning to the inter-rai suite of instruments because, of course, they're proven, they're validated, they're reliable, and it allows states to actually compare themselves to other states in ways that homegrown instruments do not allow. And so we do see, a lot of kind of momentum building, and are really excited to see Alaska coming around after a long period of kind of considering inter-rai. And so this is the current footprint of inter-rai in the United States. And so this is actually not including the U.S. version of the long-term care facility instrument. The long-term care facility instrument was actually inter-rai's very first assessment instrument in the U.S. A version of that we call the minimum data set, or MDS, is federally mandated in all U.S. nursing homes. But when it comes to some of these other instruments that are being picked up by state Medicaid programs, the states that you see in green either have inter-rai contracts or they're currently in the process of getting inter-rai contracts. And so most of these states are using the home care instrument, which is the inter-rai instrument for older adults and adults with physical disabilities. But we're seeing more and more interest in the intellectual and developmental disability space. We also are seeing several states that have recently come on to use the mental health tools. We have a few states who are newly interested in children's instruments. And so we really have seen a big uptick in interest. A lot of it is part of this Enhancing inter-rai project that I mentioned in my introduction. We've really been able to kind of raise the knowledge and awareness of inter-rai over the last few years in a way that's brought in a lot of folks, even if they're not participating in Enhancing inter-rai. I think it's really done a lot to make people aware of the opportunities that inter-rai presents. So just to give you an idea of where Alaska is, you'll hear a lot more about what makes Alaska unique, but it is the northernmost state in the United States. It's geographically separated from the mainland. It is the largest of the U.S. states, but it only has about 740,000 people, so it's also fairly sparsely populated. And Caroline and Cherry will be telling you a lot more about Alaska. To give you an idea about size, this is the adjusted for the distortion of the Mercator map and everything. But this is the actual size of Alaska against Australia, just to give you an idea about the space that we are talking about today. And with that, I will hand it over to Caroline.
Thank you, Melanie. So the Division of Senior and Disability Services, we're housed in our Department of Health, and our division has approximately 160 staff. We have a variety of functions within our division, and some of our functions include adult protective services. We have teams of assessors and support plan reviewers. We have a team that administers grant-funded services. We have an infant learning program. Of course, we have a quality assurance unit that looks at performance measures, among many other things. We have a provider certification unit. We provide training. So we do a broad scope of functions within our division. So you'll see our mission statement. And I do like to point out that the photographs on here are people who have accessed services through us and have given us permission to share their pictures. So we do appreciate that. But our mission statement at Senior and Disability Services is to promote health, well-being, and safety for individuals with disabilities, seniors, and vulnerable adults by facilitating access to quality services and supports that foster independence, personal choice, and dignity. So Alaska is a large state, but with that small population, as you heard Melanie saying, about 740,000 in the state. So the municipality of Anchorage, where Cherry and I are situated, in around between letters H, hopefully you can see the little dot above H there. Anchorage has about 284,000 residents. The fastest growing region within Alaska is the Matsu Borough, Matanuska-Susitna Borough, which has about 119,000 residents. That area is between kind of D and H. You can see Wasilla on the map just across from D. So that area is the fastest growing right now. And then the third largest borough is the Fairbanks North Star borough, and it has about 94,000 residents, and that is up between G and J. And what you can see here on the map is our road system. So you can see that there is a lot of the state that has no roads. We also have extreme population density contrasts. So in the Anchorage area, we have about 167 people per square mile versus the Yukon-Koyukuk census area, which has fewer than 0.03 per square mile. And that Yukon-Koyukuk census area stretches from Fairbanks toward the center over towards the west. So because we have a very limited road system, and some of those roads are not maintained roads, many of our communities are accessed by plane, boat, four-wheeler, or snow machine. So we certainly are challenged with transportation. When we think about the size of our population, and then we think about the people that our division are serving through waiver services and personal care services, this is a snapshot. And I just picked the services that we would be working with inter-rai on. So this is not all of our services, but it's the ones that we would be using our inter-rai tools for eligibility and determination of hours. So you can see the numbers of people served. We have 5 waivers. The Alaskans Living Independently waiver, that's mainly for older adults. We have a children with complex medical conditions waiver. You can see we only serve 236 people, children on that waiver. We have 2 waivers that support people who have intellectual and developmental disabilities, and they support 2108 and 536 people. Our 5th waiver supports adults with physical and developmental disabilities, and there's 176 people served on that waiver in state fiscal year 2024. For personal care services, people do not need to meet a level of care determination, but they do need to meet Medicaid eligibility, like what Melanie was talking about earlier. And this is that they have a need for activities of daily living or instrumental activities of daily living. We support 1,575 people through that program. For an applicant to apply for services with us, they need to work with a care coordinator. And care coordinators are certified through Senior and Disability Services to make sure that they meet qualifications and have experience, but they're not state employees. Rather, they are independent and they bill the state for their services. And the services that they bill for include gathering medical records, completing applications for services, developing a support plan, which is ultimately the request for services. And then they maintain a minimum of about monthly contact with recipients to monitor services and ensure the needs are being met. Those monthly contacts are not always in person. We require at least 2 visits per year be in person, and other platforms that they use on the in-between months are determined between the care coordinator and the recipient as to what the recipient's choice is. But usually it's telephone calls or virtual platforms where they can connect. Like Melanie had mentioned earlier too, for waiver services and for community first choice, we do require that an applicant meets an institutional level of care for services like those. And for personal care, our assessment determines the number of hours that a person would qualify for. So our current process to assess if applicants are eligible for waiver services and meet the institutional level of care, we use these 2 tools, the ICAP, which is the Inventory for Client and Agency Planning, and we use a consumer assessment tool, which we call the CAT. So the ICAP, I'm not sure how many people might be familiar with that, but it's starting to become a fairly outdated assessment tool at this stage in that it's paper-based, it's scored on a laptop that has a very old Windows application, and it contains some language that's outdated at this stage. For example, it references the yellow pages, which most people don't know what that is anymore. The ICAP produces a 3-page report, which has very limited information and is not a very good tool for person-centered planning. We use the ICAP to determine if somebody has an institutional care facility level of care. So for people who are on our intellectual and developmental disability waivers, we use the ICAP. And then we have a team of assessors who are trained solely on the administration of the ICAP. The consumer assessment tool is largely a homegrown assessment tool that we modeled on the MDS that's used in nursing homes, but it is a homegrown tool and it's built into our existing case management system. So that does bring some limitations. It determines nursing facility level of care, and it also will calculate a number of personal care hours that a person may qualify for. So we have a second team of assessors that are trained to administer the CAT. And then once a level of care is determined and we send that report out to the care coordinators, they develop the support plans, which are then submitted to us with the services that are being requested for the recipient. So we have several challenges with our existing system, and some hopefully will be solved with inter-rai and others we'll work through. But some of our main challenges right now are that individuals, many of them live in remote areas. They're not easily accessible for us to get to by our assessors. We have periods with very tight budgets in the state, which make it very difficult to cover the travel costs and hire sufficient staff. And oftentimes we need to charter flights to get to certain areas. There's not airlines that go there, so they can be very, very expensive. Certainly technology is not always accessible, particularly in remote areas. And we have had some experience in the past couple of years where fiber cables were cut and we had areas without any internet for a period of time. We have a current workforce shortage and we have difficulty hiring qualified assessors. Just a few years ago, we did, instead of particular degree types, we started to use a competency-based system for matching experience with degrees to try and bring on more assessors, which has brought some success, but it's still a challenge. Our current tools do not allow for good person-centered planning. The reports that are generated from them don't provide a lot of information about the person's needs and are difficult to use for planning. They also cannot be used for resource allocation. We actually did do some work on that in the past to see if we could use them for resource allocation, and they could not. They do not generate any sort of trending reports, and we can't use them for data analytics. And so that is quite a challenge. And then you heard me say we have two separate teams that are trained on our different assessment tools. There's very different training involved with each tool. And so we've not had the opportunity to cross-train assessors to where they could assess for any population. For example, our CAT tool takes between 4 to 6 months to become fully trained on it. And so we don't want to pull assessors away from the other team for 6 months to be cross-trained. So that's challenging for us when one team is short-staffed versus the other. So there's many reasons that we're looking forward to changing to the inter-rai. It's just such a wonderful opportunity. And I'm going to turn it over to Cherry, who's going to talk a little bit about how our project came about and what our timeline looks like.
Thank you, Caroline. Well, this timeline depicts kind of the official start of our project about a year ago. Although Alaska's been courting or dating inter-rai for quite a while now, 10, 15 years or more. Some staff goes back to 2005, I think, working with inter-rai. So we've been admiring the opportunity for many, many years. We've had efforts to implement inter-rai in the past that were sidelined by changing priorities at the state and federal level. And that little thing called the COVID-19 pandemic also played a role in some efforts that were underway at the time. So we're happy to be started now, thanks to the advocacy of stakeholders. This is recipients, providers, and a large group of individuals in Alaska that lobbied the state legislature. We received some funding in 2023. We're using that funding to begin the inter-rai implementation process and use that as essentially seed money to seek federal funding to help support this multi-year implementation project. We talked a little bit at the beginning about how many years it might take. It is many years. You'll see that here in the timeline. But yes, we were happy to have that seed money and some strong advocacy from our stakeholder groups that continue to be present throughout the process. The implementation of of the inter-rai tools is greatly aided by the partnering with Advancing States. That's an advocacy group, another great partner in this process, and HCBS Strategies, of which you've heard Melanie say that she's a member of, and the Enhancing inter-rai initiative. Without their support and the team at HCBS Strategies and Advancing States, this complex project would be a tremendous challenge to implement successfully. A lot of lessons learned from other states who may not have been so successful. So we're benefiting from that and the support from HCBS Strategies. As of today, we're in the process of finalizing the procurement of a software vendor. So we're hoping to begin with a software vendor by the end of this year and the implementation process from there. We are going to be implementing 3 inter-rai tools in Alaska over a roughly 5-year period of time. That's our goal. Overlapping phases, as you can see here, of planning, development, testing, training, and implementation. As a note about the testing phase, as we talk about the remote qualities of Alaska as well as Australia, we are going to be testing the software tools from remote locations to ensure the mobile platforms work well, both offline and online, to ensure the work and the tools work seamlessly throughout the state. That can be a challenge, as Caroline mentioned earlier. The purple timeline that starts currently represents the home care tool phase, again, for the folks on the personal care services and the various aging and physical disability waivers. That will replace that CAT tool that Caroline just spoke of. The orange timeline, you see it overlapping a bit with the purple timeline, represents the ID and the ChYMH-DD tools. Those are acronyms I hope maybe this group understands. But we're looking at 2 tools for the ID population, and that will replace the current ICAP. And you, again, heard Caroline speak to what the ICAP does and its outdated functionality and content. So these phases overlap in design and development, again, with the assistance of our vendor and our soon-to-be automation vendor, and of course, HCBS Strategies. We're looking forward to a successful implementation. We'll talk a little bit about what our plans are after implementation. Once the tools are live and we're out in the field, we're using them, we're collecting data from all the various populations we just mentioned that will be assessed using these tools, we will look at the data and we will review the outcomes for opportunities to refine policy and processes to align with division program and policy goals. A lot of refinement in that phase. It will also be a time where we will be reviewing and designing resource allocation, which is very important as well. We're hoping that that resource allocation would advance the division's capacity to deliver high quality, data-driven, person-centered care. So that post-eligibility work or post-implementation work is going to be key to our success and making sure we take the time we need to make sure we have the outcomes we're looking for that meet programmatic and health and safety needs and all the service outcomes that we are driven and have as goals in this project. The division is excited to be on the journey to modernize our assessment tools in Alaska and using inter-rai. We look forward to learning more about our recipients, gaining a better understanding of the population health in Alaska, and implementing new approaches to service planning and flexibility using the inter-rai tools. With that, I'll turn it back to Melanie, or maybe Caroline.
Yeah, I think
Next slide.
It comes back to me just for a few minutes.
Thank you.
So, so as we go about this very large change for our system, the change management piece is critical. And I know that we have people who don't like change. And something that's very important to us with this changing assessment tool is making sure that people don't lose eligibility because of a tool. So we want to be very careful with our messaging. So we have started to do things like have stakeholder engagement, both with our internal staff who are going to be using the tools, and then also for our external providers, families, and recipients. We did already send a brochure to every recipient who has been assessed by us with either of the tools that we're using now, the ICAP and the CAT, just to alert them that a change is coming and that they will be seeing a new tool in the future. And we've committed to that we're going to continue to message them as this change progresses. We've had facilitated meetings with staff to allow them to ask questions, air any fears, make sure we're thinking about everything, and that we can care for it. We've done presentations live at conferences, and then we've recorded presentations, which we've put on our YouTube channel so that the messaging is getting out there about the change that we're implementing and about the positive things that inter-rai will bring to the state. We do regular updates to our provider associations. We have some associations that we meet with monthly. And as this project is going down that trajectory, we're providing regular updates to them. And then we have an email inbox set up that we will take questions, comments from staff, providers, recipients, and families. We wanted all of the questions to be able to come to one place so that we can care for them and develop frequently asked questions documents. But if we move to the next slide, where I was referencing change, what we did not want to do is completely change what makes people eligible for our waivers and what makes people eligible for personal care hours. So on the third bullet here, you can see something that we've been doing through the past year and are continuing to do is we're crosswalking our policies, our regulations, our current tools, and we're crosswalking those with the home care tool, and we'll be starting with the ID and the ChYMH tools as well, because what we want to make sure is that we are replicating our level of care process and our personal care hours assignments process. So it's very essential that it's the characteristics that are assessed do not inappropriately make people ineligible or change their hours. And this is what we're trying to make sure we message to the families and what we're working with Melanie on very, very carefully as we go through the tools. Especially as we start down this path, there's so many opportunities later to refine level of care, to possibly serve people that are not currently being served. So I think there's so many opportunities later down the path. We want to make sure we are unrolling this change to everybody in a very planned way. Something that's very important to us is that accessibility issue. In winter, we often can't get to a remote area at all. We may not be able to fly in for weeks at a time. It's very difficult for a state assessor to get out to certain parts. So what we've done in Alaska in our current system is we have routines of in-person assessments, and then on in-between years, we will do file reviews where we'll take a look at the medical records to see if there has been any material change. If there has been change, that may dictate the need to do an assessment, whether we use virtual platform or an in-person. Or if there's no change, we may be able to just use a file review. So something that I'm excited about with inter-rai, and I saw one thing pop up in the chat, and I'll look at the chat in just a few minutes when I have my notes shrunk, is we are planning on using the entire home care tool and ID and the ChYMH. We're actually working with Melanie to add some pieces to it to make sure that we can calculate our personal care hours from those tools. And then we may consider some of those additional inter-rai tools in the future for in-between years, like the self-assessment or the check-in or check-up. Melanie, I might have got it wrong, but I love that inter-rai has other options for us. So when we think about quality data, that is certainly something we'll be taking a look at as we go forward. We may not do it in this first kind of 5 years, getting the project off the ground and getting the assessments up and running. We will more than likely use our file review years while we're getting going. But then once we have it in place and we are running with this, then we do want to consider what other tools and what quality measures they will bring for us. And then if we go to the next slide, I know I want to make sure we have time for questions. So when it comes to considering our Indigenous population and their perspectives, Some of our struggles are language barriers. It's very difficult to find translators for a lot of our Native Alaskan languages. And so we do allow for family members to translate for us when we have that need. We have that written in, the ability to do that. We have found when we are conducting assessments with our Indigenous population that they value the face-to-face interaction, and they have valued that time with the assessor present. And so we try to build in enough time, some carryover time for questions and for people to be comfortable with the process. In Alaska, we have 30-day public comment periods when we're doing changes to regulations or waiver amendments, but we allow 60-day tribal consultation for our Indigenous populations. And this is largely because we have subsistence activities that people are engaged in, seasonal activities, and people are often gone from their community for weeks at a time, for subsistence fishing, moose hunting, things like that. And so we have to make sure we allow time for those activities and to be able to connect with people. So that is what we've prepared for today. I'm sure hoping that it meets some of the needs, and I'm looking forward to, I think, Melanie, you're going to take a look through the chat and see what we can respond to.
Yeah, absolutely. So I think we've addressed Lisa's questions, though the first one indirectly, one software vendor for inter-rai in Alaska, which is typically the case in states in the US. A state selects a software vendor, or it can get more complex, as Lynn knows, but ideally that's the way it works. There was a question from Karen that I think is about what happens after the assessment. So if I'm understanding the question, how are supports actually provided to people? And so your program doesn't directly provide supports. You all provide the funding for the supports. So how does that work in these very remote communities?
That is absolutely true. And this is a challenge because we do have certain communities that are not supported by provider agencies. And so we have a consumer-directed personal care program where if a recipient has a family member or somebody who would qualify as their personal care assistant, for example, they would have to find an agency that does support that area, even if they don't have an office in the area. A lot of our providers do support areas out in more rural communities, but not all. So depending on the needs of the person, they sometimes have to move to a more urban area, which is not their first choice. So we do our best to try and help grow our provider base, but it is a struggle. That is often a balance that's difficult.
So Melanie, we can, if folks want to ask a question, they can pop their hand up. But while they're thinking about doing that, I'm interested in the people who are delivering the care. How are you imagining I can see that you're proposing to use inter-rai tools for eligibility assessment. You're using them for initial care planning, the setup phase, and you're going to use them for resource allocation as well, which is what they're designed for, all of these things, of course. But how will the actual providers touch the system and make use of it? Will they have access to the assessments? Will they interact with it in any way? Are they able to change it, or how does that process work after persons enter a program? How does the provider interact with inter-rai?
That's a really great question. How we currently do things is those reports that are generated as a result of an assessment are sent to the care coordinator, who should share them in a person-centered planning meeting. But we also find that usually there's a provider representative as part of the assessment as well. They're there with the recipient, either telephonically or virtually or in person. So more often than not, we have at least one provider representative with the recipient and the care coordinator during the assessment. But I think, Melanie, inter-rai generates a more robust, much more robust tools, those scales and caps that can be used. So we certainly have on our timeline that we will need to do a lot of training for providers so that they will understand what information those tools are bringing to the planning team. So we have that on our bucket list of things that will have to be done as we implement inter-rai.
One other thing to note is that as part of the Enhancing inter-rai initiative, there are some folks on the Alaska team who are participating in a work group where we are specifically focusing on using information from the inter-rai assessments to inform care planning and developing resources to help with that. So I think this is an area that by the time Alaska is ready to, is fully launching, that will additionally have some more tools to help with that as well. There are a few questions in the chat. Didn't mean to cut you off, Lynn.
Oh, no, I was going to draw your attention to the questions in the chat, so away you go.
Okay. Margaret asks, are the people who complete the assessments registered health professionals?
No, we wouldn't say they were registered health professionals. We do have a nursing unit, which is historically very difficult to recruit for. So we don't have a large nursing team, and they tend to do the assessments in hospitals, for people who are preparing to discharge, either in hospitals or our psychiatric institute or nursing homes. So for people who are discharging from those facilities, they will do those. But other assessors, for people who are assessing with ICAP for people with intellectual and developmental disabilities, we've had a requirement that those assessors meet a qualified intellectual disability professional credential, which is a degree type plus experience working with people who have disabilities. And then on our nursing facility side, we're looking for assessors who have the equivalent of a 4-year degree in health management, business degree, CNA, like certified nursing assistant, associates of nursing. But really the experience can play a large part. And we had to change that when we just were not able to recruit people. It's one of the reasons that our training is so extensive and takes so long.
And I'll just add that that's pretty typical in the United States. We do have a few states that use registered nurses to do these kinds of assessments, but that is the unusual outlier. It's far more common for these to be non-clinicians in the US context. Next question, Lisa asks, do you anticipate translating assessments for Indigenous populations, and also will the assessors be Indigenous?
We would certainly love to be able to recruit assessors who are Indigenous, because that would be incredibly helpful for us. We do have a couple, but not a lot. And we do translate assessments currently. When they're during the assessment, we will always try to bring a translator on, but frequently for our native languages, because there are so many of them, we struggle to find translators outside of family members. And so we often have to recruit a friend or a family member who can do that for us. A lot of our Indigenous population does have English as a second language.
And as far as like a full translation, like a written translation of the inter-rai tools, I don't think that that's in the plans right now. And I think that would probably be a very big lift, because there'd be a number of different languages that would need to be developed. And so typically in the US, the way that this is approached is just kind of what Caroline just said, where a translation professional is either present for the assessment, or in some states they use a distance connection for a translator, either by phone or by Zoom or something similar to that.
Melanie, this is Cherry. I would add, just for perspective, that just the diversity of tribal affiliation we have in Alaska, we have over 229 federally recognized tribes in Alaska. And that's so many different languages, dialects. I think it's over twice what there is in the United States altogether. I'd have to look that up. But I just wanted to add that it's incredibly diverse for being a small populated state. There are a lot of different tribal units and cultures and dialects and all of that.
I've got more questions, but does anyone else want to make a comment or ask a question before I take the floor? Let me.
There's one more in the chat.
Oh yeah, go
Asking a
ahead.
little
Go ahead,
bit.
sorry. Yes.
Yeah, asking if you could describe just a little bit more the extensive training that your assessors go through.
Yeah, it is extensive. And this is one of the reasons I'm really looking forward to our inter-rai, because there's a more standardized training available already for inter-rai. But what we do, we have classroom style learning for the first few weeks where we're going through the tool, going through medical conditions, diagnoses you may come across, going through how our system works. We have a safety module for people, you know, to maintain safety protocols when they're out in the field. There's a whole travel portion of our training, particularly, you know, how to prepare for traveling to remote areas, how to have the clothes that are appropriate for the weather, how to prepare for being weathered out and not able to return. And then there's a period in the training where assessors are shadowing assessors that are already working and in the field. And then new assessors are shadowed by experienced assessors as they start to do their own assessments. There's a period of time where all of their assessments are being scored and they're not released to be independent until they're fairly error-free. And, you know, that can take quite a while. So yes, hopefully that answers the question, Karen.
So Caroline, and everyone from North America. So there's so many parallels with what you're telling us in these circumstances we have here, both in terms of the populations we serve, but also in terms of the kind of legacy assessment and resource allocation arrangements we have here in Australia. You know, we've got bespoke tool sets that have been, you know, created here that are not related to anything anyone else uses, and all those kind of issues that you talked about. I'm really impressed by, you know, the way you've got a rollout plan there that looks, you know, in the detail and in general really coherent. So I'm sure in the detail there are lots of wrinkles, but maybe I could ask you. So you're halfway through a pretty big journey, I can see. With hindsight so far, what would have you done different 5 years ago? Are there things that you kind of would have done differently now that you've got this far into the journey, or could have you made it more rapid? Or what can you say about that?
That is such a good question. When I think about in the past, the times that the state of Alaska has thought about inter-rai and implementing it, much as I was disappointed at the times, now I look back and think we were not ready. We were absolutely not ready. I think what has made it much more ready now is we really are getting the support from HCBS strategies and Melanie's enhancing inter-rai. I could not imagine doing this without her support as we walk through the tools and trying to replicate our current levels of care so that we don't end up with nobody qualifying for the waiver anymore, or everybody qualifying and sending the budget all sorts of ways that we didn't predict. So I feel like we have a much more planned approach with Melanie's help as far as the tools go. But the other thing that I think is really contributing, you might have to ask me, Len, in a year, is there anything I would do differently? But right now, I'm feeling that something that's working very well is Cherry is the project manager over this project and is very focused on software procurement, funding, and all of those really important elements that are very necessary part of a project. And I focus on the programs. So I'm really focused on the level of care eligibility. I'm focused on the personal care hours. I'm focused on the change management and how to bring people on board for this change. And I feel like the two perspectives are working very well right now. I would be the optimistic one saying, oh, we'll be good in a year. And Cherry is really good about saying, no, we have these 10 steps. Hold your horses. We have to be doing this thoughtfully and planfully. So I really think it's taking the approach of both the project and program to make this, at least so far, we're on a good path. And I feel very confident with Melanie and Cherry's help that we will have a successful rollout. Now, I'm really hoping we get a good software vendor, you know, and I'm hoping that we can have a full team of assessors that will get trained. So I have a lot of hopes as well.
Yes,
But so far, we've gotten a lot further than we ever have in the past, and it's feeling like we're going to get there.
it's very exciting.
Terry or Melanie, would you have anything to add to that?
No, thank you, Caroline. I would agree. I think you're spot on, having been at STS for over 10 years, that we thought we were ready 10 years ago. I just really think the infrastructure that we have in place now is really foundational to the success we hope to continue with. We are experiencing some successes. Of course, we're subject to funding and state and federal impacts, things outside of our control that may hijack us here and there, but we're committed to this road. And I think with the resources we have available, I think, yeah, we're going to get it done.
Yeah, so there's some really important lessons there I can see about, which kind of falls to inter-rai, or at least some inter-rai affiliated organisation, to provide the kind of know-how to get through this very complex journey. It's not I like the tool, let's start it next Friday. You know, it's which is what a lot of people imagine with assessment systems, but it's so complicated and it's so central to how the whole thing functions, the whole service functions, that you have to get it right. And so I think the message is hasten slowly from what I'm hearing. There's one more question that Sally's got in the chat. Maybe if we could address that, then we might have to close because we're out of time. But Sally asks about how you're proposing to link your inter-rai services to primary care and to allied health services, which are sort of, I don't know how they're in Australia, they're kind of separate entities that also have an important role to play in caring for people. What's your thoughts about that?
I might take that just real quickly. So in the US, the systems are very not connected, very disconnected.
Welcome to the rest of the
there
world.
Yeah, right. There are differences in primary payers. There are differences in the how things are organized. Right now, with few exceptions, there's not great connection really anywhere in the US between HCBS programs and primary care, medical care. I will say that we've been talking about some of the outputs that could come out and some of the summary reports that could come out. There's, the possibility of creating a summary report that could be shared with a primary care physician, or could be shared with other folks on the care planning team. I think that's down the road a little bit for Alaska, though.
Well, I think I can speak for everyone. That was a really fascinating presentation. It's so interesting to see how you're going about this. And I think there will be ongoing need for us to keep a watch on what you're doing. Obviously, Melanie and I will should talk more, Melanie. But the Alaskan situation has so many parallels, at least to significant parts of Australia in terms of the isolation, and like the whole of Northern Australia. It's kind of echoes what you said about Alaska. And but of course, there are also lessons about implementation in the whole of the country, no matter what you do. So thanks, everyone. Thanks, Tony, for joining us, and thank you to the audience. I think we've got one more webinar planned for the rest of the year, but we have plenty happening on the promotional front, and things like Kinnexus and other things are really important developments for inter-rai in Australia. So for those of you listening, keep watching. We'll talk soon. For those of you listening to this conversation who may have further interests in inter-rai systems, please visit our website, interrai-au.org.